Bijoy.
Hey, Lauren.
So it's pretty exciting. We wrapped up ISC today. What were your overall impressions?
I was, lots of clinical trials, and I could see the buzz on social media too. So, and I would say, the intra-arterial stuff with thrombolysis and the extended time window thrombolysis trials were exciting.
Yeah, absolutely. I mean, I'll guess I'll start with the big picture, right? Which is we had record attendance, record numbers of randomized clinical trials submitted, record numbers of abstracts, and so it was great. Just a great high energy conference, and so much fun to be here.
That's right. That's right. Yeah. The weather was a little bit damp, but then, people liked being in. Science was exciting. And so, yeah, so this was a great conference.
So maybe we talked a little bit after the opening session about the distal and MEVO trials being sort of changing practice. Maybe we'll shift to what we learned yesterday. Um, I think the sort of big one was Transport 2. So that was using transcranial direct magnetic stimulation for recovery. So I think the trial did an outstanding job of demonstrating the feasibility of this approach, of being able to randomize, testing two different stimulation levels, showing that patients tolerated it, and giving an enormous data set to now learn from and design future trials. Obviously disappointing that neither of the dosing showed a sort of benefit in the Fugl-Meyer, but I think a huge step in the right direction and an opening of a door for what's to come.
Yeah, I agree, Lauren. For me, I also felt that the two blood pressure trials
Yes.
were very, I would say, practice informing. The idea that post endovascular treatment now, even acutely, that you shouldn't actually be doing too much to the patient's blood pressure is very informative, as was the ICH ADAPT 2 trial that was telling us in patients with intracerebral hemorrhage, where we think we ought to drop blood pressure, there really is no harm in dropping blood pressure. We can go ahead and do this. So that dichotomy, which we think is biological, is now proven by evidence, and that to me would help our clinicians manage their patients, and so it was very practice informing.
Yeah, I agree. And then moving to today, we had LAMP, the LAMP trial. So liraglutide, the GLP-1 receptor antagonist, showing a benefit. It was a small trial. It was stopped early, but yet the effects were demonstrated with a reduction in. So this was in patients with diabetes and minor stroke or TIA, a reduction in recurrent strokes, and also sort of signals towards improved recovery from improved outcomes from the index event that led to the randomization. So that's an exciting, new class of medications giving us data in the stroke population. Fantastic. Obviously, larger studies will be needed.
Exactly. I think those are really robust results, and I'm quite looking forward to GLP-1 and stroke prevention in the future. Some of my colleagues have been texting me, asking me whether we could now prescribe GLP-1s, but like with the more trial results in the future, this is a new area for us in stroke. What do you think about um, thrombolysis trials that were presented today?
Oh, there was a lot going on in the thrombolysis field in context of both the extended time window, more data suggesting that with good patient selection, that and patients predominantly not going to mechanical thrombectomy, signals for benefit for thrombolysis, which is fantastic, right? We have little to offer those patients, and it is the bulk of patients worldwide. So that was really nice to see the widening of the window out to 24 hours. Um, and some interesting hypotheses about why some these trials are positive now, where some of the other trials in the
Right.
past were not, right? And so that gives us a little bit of biological plausibility, right, in terms of believing the results. Um, and then the post mechanical thrombectomy, trying to treat this no reflow phenomenon and translate proximal revascularization to improved patient outcomes. Studies with both alteplase and tenecteplase both showed benefits. Although of note, DATE, which was the sort of dose finding trial, didn't see a signal in terms of improved outcomes. So I think we'll have to tease apart, was that patient selection, was that location of the catheter, um, but certainly more data sort of leaning us towards that uh, intra-arterial thrombolysis is a great adjunctive friend to
Yeah.
mechanical thrombectomy.
Yeah, I agree. I think it's just opened up this avenue, additional avenue for us to
Yep.
treat our patients. And I think, a future definitive trial, if that actually shows signal, then it means that, you know, as it happened in the past where thrombolysis came first, then thrombectomy came on, and then there were questions about thrombolysis. But now I think, both these treatments actually becoming friends. And then what we are trying to find out is where do we give one vis-a-vis the other. So that's exciting. Um, what did you think about the last trial, the best trial, the PSD95
Yeah.
inhibitor? And I say that because of my own experience with the Escape Next and the Escape NA1 trials, where we did have some negative results, and we are now trying to um, do what the best folks did with the phase 2, but now in a phase 2B manner,
Mhm.
try to give the PSD95 inhibitor very early. But
Right.
do you think that the best trial results were?
Certainly intriguing. We're continually searching for that holy grail that can protect brain tissue in the context of ischemia. And this is just another approach at hitting PSD95 as one of the most promising targets. Again, small,
Yeah,
early results,
absolutely.
but and early enrollments, right? So median enrollment, I think, was around 130 minutes. It was, you know, uh, many of the patients also got IV-TPA, which was, great to see. And, at least in the highest dose, strong signal towards, a potential benefit. Granted, just missed the p-value,
Yeah.
0.055, but, that looked like there was a dose finding. It looked like there might be something there. Um, we'll have to look a little bit more carefully at those secondary endpoints because it didn't look like there was a signal, throughout all of them. But a well-executed trial, and hopefully we'll see more testing the target in the future and in larger numbers.
Yeah, and I think it just shows proof of principle that the earlier you give the neuroprotection, the higher the chances possibly that it might work. The other trial that I think, in my opinion, will inform our practice was the Prestige AF trial.
Yeah, right.
What are your thoughts on
Yeah, I
that
think
trial?
the big congratulations to the group for getting the uh, results out. The you know so the addition of anticoagulation to those patients with atrial fibrillation and a history of
CH.
ICH in the last year, has been a big conundrum for us. And so, not surprisingly, the oral anticoagulation reduced the risk of ischemic stroke in patients with AFib. That's
Yeah.
quite logical, and we would expect that. But it was offset at least partially by an increase in the risk of intracerebral hemorrhage in the ICH survivors. So I think that that magnitude of benefit is still uncertain. A little different trial design than some of the other ongoing trials, where the choice of antiplatelet, or even if they were going to be on an antiplatelet in the control group, was more variable. So I think that will be really helpful in the context of also Aspire and Enrich AF and other large trials that are coming out.
Yeah, I agree. I think, having randomized evidence now, having a better understanding of the risks and benefits is very useful for physicians, for our neurology colleagues, because then they can pass on this information to patients, and then we could make thoughtful decisions. So I think from that perspective, Prestige AF is the first of, I think there are a couple of other trials, as you said, Enrich AF and Aspire, that like guide our practice. So that was, I think, quite interesting and useful. I don't think we have anything else, do we? Are we
Yeah,
done?
maybe I'll say one other area that was in secondary prevention with the C3 Fit results, that when you have sort of continued engagement with patients and their families after a stroke, you can reach some better risk factor control. Um, and so that, you know, also, should be logical, but it's just not the way we've practiced care for our stroke patients. And so it was nice to see that this real effort of engagement had some tangible benefits on risk factors.
Oh, I agree. Yeah. And I think Dr. Howard, who presented C3 Fit, he was telling me that they were actually looking at outcomes at around 2 years, but because of the pandemic, they couldn't actually look at the primary outcomes at around that period. But I do think the interventions work, and we could see that from drops in HbA1c, the blood pressure control, but then the effect on clinical outcomes, the fact that he did not show it, I don't think it means that there was no effect. It's just that if you follow these patients for longer, then you start seeing effects. So from that perspective, the C3 Fit trial to me was a positive trial.
Yeah,
It tells us what we need to do. So.
absolutely. All right, and then I think wrapping out the posters and tremendous advancements in genetics, genomics, preclinical work, new biological targets, prevention, recovery, just a lot of exciting science this year. And um, yeah, session submission is going to be opening soon for next year, and we
That's
can't wait
right.
to see
We look
everyone.
forward to next year and lots more. Thank
Absolutely.
you.
Yep. We'll
Thanks,
see you in New
Lauren.
Orleans.